Hello, this is Michelle Trenka giving you a lecture on pediatric assessment and how it differs from adults. So why do we monitor patients in general, no matter what the age? We monitor them because we want to know if something's wrong. You know, if their vital signs are outside of the normal limits. We may need to get the vital signs and the assessment to help with an ongoing diagnosis. And it might be that we're doing it because we want to make sure our patient's not going down the tubes and not doing badly. For most of us, what we do outside of critical care is non-invasive monitoring. In other words, we haven't put anything inside a patient. And that's what we do for most of our patients. And one of the biggest parts of assessment that we're going to do in pediatrics is perfusion status. If our kid has a good cap refill and good palpable pulses, they're probably in good shape. So you'll hear me very frequently say when I'm talking to people about their patient, are they pink, warm, and well perfused? Because if a kid is pink, warm, and well perfused, they're stable. We also need to know what their temperature is. Especially in infants, infants have a great difficulty doing temperature management. They can't maintain a decent body temp. What's their heart rate? If they're tachycardic, there's something going on. If they're bradycardic, there's something worse going on. What's their mental status? There's a big difference between awake and comatose. There's a lot of stuff in between. I've had children that I can go up to, stick them with a needle to try and start an IV or draw labs. They'll look right at me and not respond because they're not comatose, but they have an altered mental status. What about their respiratory rate? What's their work of breathing? What's their SATs like? What's their blood pressure cuff? Notice I put blood pressure as the last one of the non-invasive monitoring because in pediatrics, we don't really care as much about blood pressure as we do in adults. So what we're going to talk about is how we recognize a patient who is going from fine to not so fine to difficulties to failure and shock. So one of the things that I always try and remind people in pediatrics, our number one cause of decompensation, bing, bing, respiratory. Respiratory is what's going to get them. That's why in pediatrics we do 15-2 on CPR rather than 30-2. What's the big difference between 15-2 and 30-2 is how often you breathe. Because they have found a lot of times if you can get the kids, give them CPR for 2 minutes, they may very well come back. Respiratory failure and shock is another big thing that gets them. And both of those, without being addressed, will lead to cardiopulmonary failure and death. So it's pretty important that we recognize when somebody's going into respiratory distress and failure and going into shock. Because if we don't catch them fast enough, they will go to God, I promise you. So when you are assessing a child, it's very different than an adult in the fact that they have figured out very quickly that that people in scrubs are evil and bad. They know that if somebody in scrubs with a stethoscope around their neck, or even worse, a lab coat, is coming into their room, we're up to no good. They've learned we give them evil things that taste nasty, or we poke them with needles, or we do even worse things. So they have learned to be afraid of us very, very quickly. So for that reason, I like to think of Nurse Nancy as Bond, James Bond. Reason being is you need to assess your patient, at least visually, before they know you're assessing them. So I like to use, a lot of the hospitals have blinds in the doorway, and most places they keep the blinds shut. So I'm going to crack them open because I want to look and see what's going on with my patient. So I'm going to look in the room when he can't see me and say, are we awake or asleep? Hot dog, we're asleep. That means I can sneak in the room and do a little more assessing before I wake them up. So I'm going to sneak in the room if they're asleep. If they're not, what else can I see from the door? Do they appear comfortable? Sometimes kids are afraid to admit that they're in pain because they're afraid they're going to get a shot. So they're going to, when you walk in the room, say, no, I'm not in pain. No, I have no pain. No, no, no. But when you're looking in the window, you may notice them guarding their incision site or whatever, is something that could be bothering them. So that's a really helpful thing to see from the doorway. How is their breathing? Do they have an increased work of breathing? Are they retracting? Are they grunting? Are their nostrils flaring? Is their head bobbing? All these delightful things that we're going to be learning about. So you need to know how much, what's the problem going on? Are they breathing okay? Are they pink? Pink is good. Blue is bad, but not as bad as gray. So if you're working with the cardiac kids, a lot of them are blue and it's okay. If you don't have a cardiac kid, blue is definitely not okay. What is their position of comfort? Am I taking care of a kid with asthma and they have to sit bolt upright in order to breathe? I still remember when I accidentally got my son's elbow dislocated when he was a little kid. And he told me it was hurting, and I kind of blew him off because, he was a kid and I'm a bad mom. And but when I checked on him in his sleep, he was holding his elbow in his hand. That told me that it wasn't just a little bump that he had gotten on that elbow, that when we were swinging around in a circle, I really did pop it out. So that's why you want to look at their position of comfort. The 10-second assessment is really helpful, and that's what you're doing as you walk in the room and you're gelling your hands and you're doing your, hello, my name is, and I will be your student nurse for today, and how are you doing? That's when you're looking at the patient because they know you're coming, but they still haven't figured out necessarily what's going on. Look at them some more, see how they're doing. One of the things I like to do if they're on monitors, I will look at the monitor readings from out at the nurse's station. What's their heart rate? What's their respiratory rate? How are things looking? And then when I go in the room, let me see, what is their heart rate? What is their respiratory rate? Has it gone up because I walked into the room, or is it about the same? When you're assessing a patient, I like you to think about the old adage of look, listen, and feel. It really is beneficial if you do your vital signs and your assessment in that order. So you go from the least touch and invasion to the most. So what can you see by looking? I already mentioned a couple things, right? You can look at position of comfort. You can look at work of breathing. You can look at their color. So I want to do that first. What am I going to do by listening? I'm going to listen to their breath sounds. I'm going to listen to their heart sounds. I'm going to listen to their bowel sounds. So I put my stethoscope on their chest and I start listening. After I'm done doing the things I can do by listening, that's when I'm going to go to feel. What's their temperature? Their trunk versus their extremities. How are their pulses? Are they palpable? What's their cap refill? On their fingers, on their toes, on their trunk. Because remember, when we're talking pediatrics, these kids have pristine bodies and functioning organs. So these kids aren't going to have difficult to palpate pulses because they don't have any hardening of the arteries going on yet. So when you palpate these kids' pulses, they should always be 2 to 3 plus. And if they're not, something's going on. Their lungs should be clear because they don't have emphysema and COPD and all the things we've been hearing about for the last, 2 semesters. And if they're not clear, what's going on? So that's why you need to be doing your look, then your listen, then your feel. If you get your vitals in that order and you get your assessment in that order, you'll have less alteration of numbers because of stimulation. So when you're talking about your respiratory rate, the first time that you're doing vitals on a patient for your shift, I really strongly recommend you do them with your stethoscope on the lungs, apical numbers. Count your respiratory rate for a full minute. Why do you want a full minute? Because especially infants, their respiratory pattern is irregular. So if you do a shorter time, you're going to miss something. You're also, during that full minute, training your ear to listen to different breath sounds. So it's real important that you put that stethoscope on the chest for a full minute and count a full minute of respiratory rate to make sure you're accurate. What you do in adults, as far as count for 15 seconds and times 4, you do not, I repeat, do not do that in children. Most hospitals have policies about it. I know Children's Medical Center, you're supposed to do the least you can do, and that's for older children, is a 30-second count. In infants, anybody under a year, right, that's your definition of an infant, you must count respiratory rate and heart rate for a full minute in order to get accurate numbers, and that's what policy states. So kids can compensate because they have these functioning organs that are going great at 100%. Nothing's wrong with them. When they get sick, they don't go downhill. They will compensate, crash. They will fall off a cliff. So if you don't catch them while they're in their compensation period, you're going to be calling a lot of codes. One of the things that I learned the hard way, and I remember one of my students telling me, is you have to be a detective if you're a pediatric nurse. You have to catch the clues of compensation so you don't have a kid falling off the cliff on you. So when you're talking respiratory status, we have to talk about what is the definition of increased work of breathing. So a kid is supposed to breathe faster than an adult, right? But are they supposed to have retractions? Because kids can have retractions. Kids can have nasal flaring. They can have grunting. They can do... It'll be amazing when you start to see a kid in respiratory distress, what they're going to look like and how they're going to sound. So those are things that you're going to have to be looking at. And when you first start assessing kids, since this isn't your norm, you're going to have to ask yourself out loud, not necessarily out loud, but that voice in your head, and ask yourself in your head, is their work of breathing normal? Are they retracting? Are they grunting? Are they flaring? And that's the way you're going to have to work it. What's their respiratory rate? So let's say they're breathing 60 times a minute, which is a pretty fast rate even for an infant. Let's look in the chart and see, what do they breathe all the time? This might be a kid who doesn't have normal heart or doesn't have normal lungs, so a respiratory rate of 60 might be their norm. So we need to understand what's fast and slow and normal for all the different age groups, but you also need to realize that not only do you have to know by age group, you have to know by patient. Where do they live? So where do they hang out? That's what we usually say. What's their respiratory rate usually? Well, he normally breathes 60. What's he breathing today? 110. Well, then he's a little sicker. Now we start to call people because it's way above norm. But if he normally breathes 60 and he's 60 today, well, then this is where he lives. We're just going to kind of go with it. What's their oxygen saturation? So we all know from working with our adults that we want everybody to be in the 90s, right? But there's going to be some kids that aren't going to be in the 90s. You might have a kid with really bad lungs because they're an ex-preemie. Their SATs may sit in the 80s. Some of our congenital heart kids, their SATs can sit in the 60s, and it's okay. And it's kind of freaking you out when you see it for the first time because you're just not used to it. So respiratory rates that are fast are really scary sometimes, but at least they're still breathing. What we really get concerned at is when their respiratory rate starts to slow. And you had a kid who was breathing 30, and now they're breathing 20, and in 20 minutes you come back and they're breathing 15. Guess where they're going next? To 0 and code. So these are the kids you're going to be real aggressive with. That's why you need to know where this kid normally breathes so that you can recognize that they're going down. Tachypnea. I've learned really hard there is no such thing in pediatrics as benign tachypnea. Now, it could be something simple like the kid's scared, they're stressed, they're in pain, they have a fever. Or it could be that they have pneumonia, that they're going into respiratory failure. So you need to make sure that you recognize this kid's work of breathing and respiratory rate are not normal. Bradypnea is even worse because once they start to slow down, they're going down the hill. They've already fallen off the cliff. You better catch them quick because they're not going to be around much longer. Alive, that is. You're going to be coding them pretty soon. And if you've got a kid who's breathing real slow, what has that kid had lately? Did you give that kid some sort of a benzodiazepine? Did you give the kid some kind of pain meds, an opioid? Could they have some, they're just super sensitive, so they have a little bit of an overdose thing going on? Or are they actually bradypneic, maybe because their neurostatus is going down? What's going on? So you need to know what is happening with your kid and what to expect. I already mentioned before, irregular respiratory rhythm is very normal in a lot of children. But if this kid hasn't had an irregular respiratory pattern and now has one, something else might be going on. So when you recognize that your kid's respiratory pattern is irregular, you need to do a little more research to make sure that this kid has had an irregular respiratory pattern for quite a while. Keep in mind, when you're working with infants, they only breathe out of their nose. This is respiratory season. When you guys go into these pediatric hospitals, they will be flooded with respiratory kids who all came in with that respiratory syncytial virus, RSV. So think about it. If I have an infant who's an obligate nose breather and they've got enough mucus coming out of their nose that they can't breathe, what's going to happen? They're going to be in really bad trouble. So we have to be able to keep their nares clean. So how do we do that? We use that little blue bulb suction of theirs, right? Delightful thing. Show the parents how to use it. Maybe the next time the kid gets RSV, the kid won't have to come into the hospital because they'll be able to keep the airways clear at home. It doesn't always work that way, but it can, and hopefully it will for these kids. So what kind of things can compromise your airway, right? We can have swelling and constriction and secretions. Who would get all three of those together? That'd be your asthmatics, right? That could also be your RSV kids. What about artificial airways? That could be an issue too. They have a trach. They have an oral airway. They have a nasal airway. We got to make sure that these things stay patent. Remember, your inner airway, right, your bronchioles, are about the same size as your pinky. For us, that's pretty good. Pinkies are a good size. Think about the pinky on an infant. So let's say that infant has some sort of a respiratory infection going on, and they're creating a lot of mucus. How much mucus is it going to take before that kid's airway gets occluded by snot? That's why we have to think about keeping them clear. Kind of mentioned this a little bit, as far as that they can do these delightful things called retractions. Remember, in children, especially small children, what is their ribs made out of? They haven't hardened into bone yet. Their ribs are made out of cartilage at this age. Cartilage is very, very flexible. That's why we always say that if you get an infant into an ER with broken ribs, before you do anything else, think abuse. Because it's really hard to break ribs on infants because their ribs are completely cartilaginous. So we need to make sure that we recognize that any retractions are going to be very impressive in little kids. Here's a good picture of retractions on this kid here on this slide. So not only does he do the breastbone to the backbone, you can see he's got intercostal, the retractions between the ribs, because you can literally sit there and count those ribs on that kid. So what would you do if you walked into a patient room and this is what your kid looked like? So not only does he have the breastbone to the backbone, he's got the intercostal retractions. He's even got some subcostal retractions. He's got his mouth gaping open. His nares, if they were any bigger, they'd be, off the chart. And he has a look on his face of utter and complete horror. That's that feeling of impending doom. You never, ever ignore it, whether it's in a child or whether it's an adult. If I had a child come up to me and show me that look, I'm pressing buttons, whether it's the rapid response team or a code team. You betcha I'm going to have a doctor or a provider in that room within 2 to 3 minutes, or I'm calling a full code, because this kid does not have long before he's going to be in the land of code blue. So I need to make sure that I'm recognizing these kind of things. I know in my career I've only had 2 adult patients tell me that they told me they were going to die that day. And believe it or not, both of them did. Impending doom is not something to ignore. So you can see how this kid is, and if you notice, he's looking really bad and he's still got his eyes open. That doesn't necessarily mean he's completely level of conscious normal. It just means that he's still awake. So we need to figure out what's going on with this kid and fix him. So as I'm sitting there calling for help, calling in whatever team I can, next thing I'm doing is I'm grabbing the oxygen and I'm going to put that on this kid, and I'm probably going to have to bag him because I've got to get his respiratory work of breathing back under control. Next thing is your heart rate. So you've counted your respiratory rate. Now let's go down and count your heart rate. Now keep in mind that when we talk about people who need an increased cardiac output, if you remember back to your anatomy physiology class, we all learned that cardiac output is heart rate times stroke volume. Well, in adults, if we need to increase our cardiac output, we can increase our squeeze. In children, not so much. They have immature myocardiums and they cannot increase their squeeze. So the only way they can increase cardiac output is to increase the heart rate. So when you see tachycardia on a child, you have to think bad things first. You can rule out the fever, you can rule out scared, you can rule out the load in the diaper, but you cannot ignore it until you have determined what it is. So when I get a kid who's severely tachycardic, first thing I'm going to do is check on them, right? Do a set of vitals. Do they have a fever? Okay, let's get rid of the fever. I'm not going to ignore this kid's heart rate until my fever is gone, and then if the heart rate comes back to normal, okay, the tachycardia was secondary to the fever. The kid's scared. I want to get this kid calmed down. Does the heart rate go down? If not, something else is going on. So what I think you can hear me say, tachycardia, bradycardia, tachypnea, bradypnea. We don't ignore these things until they're back to normal. We can try and fix all the easy fixes, but if that doesn't work, we keep working. Arrhythmias by the EKG monitoring is very rare in children outside of the cardiac arena. Kids don't have extra beats. They don't have irregular heart rates. So if you see that and they're not a cardiac kid, you better call somebody because something evil may very well be happening soon. Mental status. Remember I said I have had kids that are awake but aren't responding well. Think about it. If you've ever been around a toddler, right? They have the old stranger danger. You walk into the room and they glue themselves to mommy. They won't let mommy separate from them by an inch because there's strangers in the room. I have seen that same kid, as they got sicker, get to the point where you can walk in the room, mom can leave the room, and the kid doesn't even care. What does that tell me? Their mental status is altered. They're going down. There's a big difference between awake and comatose, and it's the things in the middle that you have to be a little careful about. They can be awake and just still have that alter. Like I said, you can stick them and they don't cry. That's a kid with an altered mental status. That is evil and bad, and we need to be worried about it. I think I already talked about bradycardia and tachycardia. One thing I do want to mention about bradycardia, though, one last thing that we'll talk about again when we get to heart rate. Remember I mentioned that infants are really not good at thermoregulation. And if you get a cold infant, you'll get a bradycardic infant. And from bradycardia, it can get even worse. So you've got to always be prepared when you get slow heart rates. What could be going on? Either are they cold? Are they hypoxic? So those are things to think about. So as I started to mention, we want to make sure that we keep our kids normal thermic, especially infants. We don't do a lot of rectal temps in pediatrics. A lot of it has to do with the fact that they have very short rectums, and it would be very easy to perforate a rectum with a rectal thermometer. So we're not going to use them unless we have to. We definitely prefer, depending on the age and what thermometers are available in the institution you're in, we can do the temporals. We can try to do the tympanics in the ear, but you have to have a decent sized ear to use a tympanic. So we're not going to use tympanics on small children. Once they get to school age, then it's a possibility. If they're old enough, we can do orals. Otherwise, what we do, even though it's the least effective way to get a temp, is we will do axillary temps on most kids. So I kind of mentioned this a little bit about hypothermia being a bad, evil thing. We need to make sure that when you've got an infant, even if they're not doing well and you're monitoring them and you're assessing them very frequently, cover them up between assessments. You've got to make sure that these kids don't lose their body temp. Remember, as it says there, neonates can't shiver, so what happens is they burn calories. And a lot of these chronically ill children that we get in the hospital, one of the big things we want them to do is feed and grow. And if we're making them have to maintain their body temp because we're not keeping them covered, we're going to lose all those calories. No bueno. If they do have a temp, we need to watch. What is it? One of the things you have to worry about in small children is febrile seizures. Now keep in mind, if you have a kid who's having a febrile seizure, it is not the amount of fever they get, it's how fast the fever rises. And usually by the time they get to about 5, they've grown out of it. I know grandchild number 1 had febrile seizures, and it's quite a creepy thing, but I will tell you, he had a little bit of fever trouble the first time he had a febrile seizure, and his fever was gone. So my daughter and son-in-law and my grandson, they went out to eat for lunch. And so he was afebrile when they left the house. By the time they were hitting dessert, that's about the time that he had a febrile seizure. His temp was already at over 103 when he had the febrile seizure. So think about how long it takes to get to a restaurant, and they're not much on appetizers, so they went right to the full meal. So you think probably less than an hour, and they went from a temp of normal to 103. Believe it or not. So like I said, kid had a febrile seizure. You want to see someone who's paranoid about kids who have fevers? You should have seen my daughter. That kid never got a temp above 99 when she wasn't throwing some Tylenol down his throat. Kind of like I mentioned before with the respiratory rate, make sure you do your full 1 minute apical pulse. You can't do radial pulses until they're bigger. Remember, that's why in CPR we do brachials, right, on infants? So when you're doing vital signs, you want an apical pulse. Not a radial, not a brachial, apical. I mentioned at the very beginning of this lecture, the number one thing that we check on these children is their perfusion. Pink, warm, and well perfused is what we're looking at. We want to make sure they have good pulses, that their cap refill is less than 2 seconds, and believe me, on these kids, if they're healthy, it is brisk. We want to make sure that it's brisk in the extremities as well as in the trunk. What color are they? We want everybody to be pink if possible. And a lot of times when they start going downhill, they may have a very nice pink, warm, well-perfused trunk, but when you get down to their hands and feet, they're cold, they're pale, and their cap refill is 3, 4, 5, 6 seconds. So that's one of the things you have to worry about. When we do cap refill on children, we do not do nail beds. We do the extremity. So foot, you can do the top of the foot, you can do the bottom of the foot, you can do the toes, but do not do nail beds. So I recommend doing it just like they're showing in this picture. Palms of the hand is where you want to go for the hands. Do not use nail beds, because your nail beds could be brisk, but then when you check the hand or the feet, you could have 5 seconds. So don't do nail beds at all in kids. Blood pressures. It's very important that we use consistency. Same size cuff, same extremity, every single time you do it, because that way you don't have to try and figure things out. You'll hear a lot of places will say on infants, we do all of their blood pressures on their calves of their legs. Be careful where you're at, because some hospitals have different policies. So you need to follow the policy of the hospital. I also, as I said before, put blood pressure as the last vital sign, because children's blood pressures will not change until the last thing. So I can have a kid with cold, clammy hands and feet, cap refills of 5 seconds in the hands and feet. The kid neurologically is no longer noticing mom is not in the room, and they were gluing themselves to mom earlier, and the kid will still have a normal blood pressure. I always say if you wait for the blood pressure to drop in pediatrics, you're going to miss the boat, the cruise, and the whole vacation, because as it says here, the kid can maintain a normal blood pressure until over 25% of their circulating blood volume has been depleted, whether dehydration or hemorrhage. But they are going to be really dry before they're going to get symptomatic with a blood pressure. So don't wait for that one to drop. Modeling is something we sometimes see in children. This can go along with the cold, clammy cap refill of 5 seconds. Modeling is not a good sign. An important thing to do in pediatrics that we really don't do, we usually blow off the spouse or anybody who's visiting our adult patients. But in pediatrics, always, always listen to the parents. They know their children. They're going to look, you're going to walk in the room and you're going to completely assess that kid, and the kid is pink, warm, well perfused, vital signs are normal, everything looks hunky-dory, and the mom says, he ain't right. And you're going to look at the mother like, what? Kid's fine. And the mom says, he never lays still in bed like this. He's sick. And sure enough, sooner or later, that kid's going to present what's going on. So if a parent says he ain't right, you keep working on that kid, and you keep assessing, and you keep nagging the providers to keep getting labs or whatever is needed until you can figure out why he's not acting right. So never ever discount the parents. The few times I did, I lived to regret it. Normal limits. This is a really questionable thing, and I know you guys all want perfect, parameters that you can memorize and use for testing purposes. Unfortunately, in peds, it doesn't work that way. When you're looking at normal limits, you not only can look at age parameters, but as I said before, you've got to see what's normal for them. Each hospital uses a different table for what they consider norm. So whatever hospital you're going to, find out in that institution what they're using, and that's what you're going to have to work with. I put a couple norms on here just to give you some ballpark figures. So you notice that what you consider norm in an adult, 120/80, we don't get there until we are an adult. So we don't get our panties in a wad if their numbers are lower, because we expect them to be lower. If you really like calculation formulas, I give you one. This is not going to be on any test. It's just one of those things that if you like this kind of thing, Merry Christmas. A little late. Pain. I think you got a lot of pain lecture from Dr. Kubin. You've got to assess pain with every assessment. Pain is the 5th vital sign. In most institutions, anytime their pain level is above a 1, some sort of intervention has to be done. Now, I'm not saying drugs. I'm talking an intervention. Swaddle them, rock them, see if there's something that you can do to relax them. Put on some TV that the kid watches to help relax. Distraction is a great thing to work on with children. So we need to think about that. But if you do have a pain level greater than 1, we need to do an intervention, and then we must go back and reevaluate 15, 30, or 60 minutes later, depending on your intervention. Remember, as it says here, to use the appropriate pain scale. And it's the pain scale that the child has permanently. So if I have a 5-year-old, a 6-year-old, who's normally using the 1 to 5 or the 1 to 10 scale, the VAS, verbal analog scale, because I can use that on a child who's old enough to understand greater than and less than. So let's say I have a 7-year-old who understands it, and he's been using that 1 to 10 scale. Well, today he's heavily sedated. Am I going to change my scale because he doesn't talk today? No. I'm going to keep him on the same pain scale, and I'm just going to document that he is heavily sedated. Do not change scales unless it's a permanent change in your patient's assessment. So I kind of put on this slide all the different types of scores that are available to us. Most hospitals will use FLAC for infants or nonverbals, FACES for children who can talk, and then that VAS, that verbal analog scale, for children who understand greater than and less than. So those are the 3 most places used. NIPS is something that's used mostly in NICUs. And quite frankly, I've not seen the CRIES scale used, but I put it on here because there's a possibility you could go to a hospital sometime in your career that uses that. But I'm pretty sure that all 3 of the hospitals that we go to use FLAC, FACES, and VAS. Weights are super important in children because weights are going to tell us all kinds of things. First of all, it lets us know if they're gaining weight or not. It lets us know, let's say if it's a cardiac kid, it lets us know that they're maintaining extra fluid on board for potential CHF. It also lets us know the number that we utilize is what we're going to order all of our medications from. Because in pediatrics, there are no standardized doses. Everything is done per kilo. So if we have inaccurate weights, we will have inaccurate drug dosing. We will be thinking that our patient is gaining weight appropriately, when in actuality, we could have somebody who's weighing a patient with a full wet diaper. So it's very important that we make sure our patients weighed correctly. So children under the age of 3, we try and get them with nothing on if possible. Weigh them completely buck naked. If you have a parent who gets very upset about buck naked baby, what we can do is change their diaper if they're still in diapers right before you do the weight and zero the scale with the diaper on it. You're going to get very good at diaper scales and baby scales while you're doing your pediatrics. I know that those of you who go to Scottish Rite, your kids are a little older, so maybe not so many diaper scales there that you would at Medical City or at Children's, but I think you might still see a few. Remember, it's just like blood pressures. Same scale, same time of day, same amount of clothing. Consistency is what you're going to get, so you know what's going on from day to day. So if they've gained a whole lot of weight since yesterday, the first thing I'm going to look at is their I and O's. Did they have a lot more in than out? So you need to kind of look at all of the different pieces together to determine, are they gaining weight because they've got fluid on board? Are they gaining weight because they were weighed inaccurately? Are they gaining weight because they're really gaining weight? So, I could sit here and talk on weights for another 20 minutes, but I think you want me to keep going. But I think you get the idea. This is a very important thing that must be done and must be done accurately. FOCs. We do this on kids until their fontanelle is closed. So the oldest ones we're ever going to do this on are 2.5, 3-year-olds. When do you do FOCs? For you guys, I would recommend that you do it just for practice if you have an infant. Every institution has a different policy of how often it's done. Neuro floors are going to do it a lot more frequently than non-neuro floors. So whatever unit you're on, you're going to need to call and ask, not call, but ask when you get there, do we do FOCs on our patients on this floor? How often? And where do we chart it? We need to understand the FOC because we want to make sure that their head is at the appropriate size for their age. We want to make sure that the sutures have not fused too early. We want to make sure that their heads are not too big. Are their fontanelles soft and flat? Are they sunken because they've had the pukes and the poops? Are they firm and bulging because they have problems with their CSF? Maybe they have hydrocephaly. So we need to figure out what's going on, and one of the ways we can do it is with your FOC. Another cool thing about kids who still have their fontanelle open, if they are worried about the kid's brain for whatever reason, they don't need to go and have like a CAT scan done. They can actually go in through the fontanelle and use a sonogram and take a look at the brain, which is kind of cool if you think about it. So I kind of mentioned this already. I&O. I can't tell you enough, if your kid is on I&O, it can be extremely challenging to do it. I don't know which is harder, when they're infants and you've got parents who forget to weigh the diaper and they just throw them away, because at home, what's the first thing they do? Throw them away. Or is it because they're older kids and they don't want to pee in the hat that's in the toilet? They just want to pee in the toilet like regular. So it can be very challenging to do intake and output on pediatrics. So I strongly recommend that you talk with your parents at the beginning of your shift and make sure that they understand how I&O is being recorded if that patient is on I&O. I know at Children's Medical Center, we put an I&O sheet in every patient room right next to the diaper stand. And there's an English side of the paper and a Spanish side of the paper. And we make sure that the parents know that it is expected that if they don't want to write it down, they have to remember to tell us every time a healthcare provider walks into the room so that we can chart it and make sure that it's accurate. I threw a couple formulas in here. I'm sure you'll see them in other places too, but I strongly recommend that you keep these in a place where you can find them, because one of the things that you need to do when you get a patient who is getting IV fluid is make sure that they're on the right amount. Because with adults, right, we have certain, 125 an hour, 83 an hour. You'll see certain numbers pop up over and over. Where with kids, we do it on maintenance amounts. So if they're just getting IV fluid, the docs may order, the nurse practitioners may order maintenance IV, which means by this calculation. Sometimes they're renal kids that don't pee a lot, so they might be at half maintenance. You have to make sure that the amount of fluid that they're being ordered is the correct amount for their weight. Nobody is infallible. It's always beneficial for us to check with each other. I think you might need to know these formulas for med day also, so keep them handy. Output, I kind of told you a little bit before about the I&Os. When you're working with diapers, right, we might have pee and poo in the same diaper. Now, unlike old people where they will tell you if their poop is 2 hours late, children don't notice these things. So we need to make sure that somewhere, somehow, we're keeping track that this kid is pooping adequately, especially if they're in and getting narcotics, which are going to constipate them. Because a kid is never going to tell you, I need to poop. They just go, right? So we need to make sure, ask parents, what's their usual pattern? Is this what their poop normally looks like? A lot of times we get kids in with rotavirus, so they come in with the pukes and the poops. So we need to know, how often are they going? What does it look like? I know you really get into describing these things. It's great fun, isn't it? Not. Psychosocial development. You're going to get so tired of hearing about growth and development, talking about Piaget and Erickson. I know I'm going to be asking my students in clinicals, what level of Piaget and Erickson are they at? Are they meeting their milestones? Are they at the right developmental age? For example, if you've got a kid who's got a chronic illness who has spent most of his time or 50% of his life in and out of hospitals, is his developmentals where they belong? Are they at the right Piaget level? Are they at the right Erickson level? Are they meeting their physical milestones? How do we determine somebody has autism? Because they stop meeting their milestones. If they're an ex-preemie, are they meeting the milestones not on their birth date, but from their due date? So we need to make sure that we're working with this, because we're the ones that catch the things. Nurses are the ones that catch if the kid is missing something. We like the docs to catch it, but remember, how many people a day the nurse practitioners, the docs, the PAs see? We're with that patient for 12 hours. So we're the ones that are going to notice, this kid doesn't act right for what I would expect a 6-month-old to act. Or this is a first grader, but this kid is, he still wants his lovey. He still wants mommy right there. He's acting as if he was 3. Well, could it be that his developmental levels are an issue? So we need to keep that in mind. So I promise you, there's growth and development on every single exam. You need to learn your Piaget and Erickson. You need to know toys for different age groups. Over and over, we are going to drum this into you, because whether or not you become a pediatric nurse, you need to know this stuff for today. You need to know it for NCLEX. You need to know it if you're a parent. So it will come back and haunt you over and over. When it comes to pharmacotherapeutics in children, something to keep in mind is, depending on the age group, is going to depend on how well absorption is going to work with these kids. Their metabolic rate is usually higher, so we may have to give doses higher than you normally would think of. For example, the one I always like to give as a good analogy is Lasix. So what is a normal Lasix dose in an adult? Usually I would think most of you would be thinking right now, hopefully, 20 to 40 milligrams. That's a normal adult dose for Lasix. In pediatrics, a normal dose of Lasix is 1 milligram per kilo. So let's put this in perspective. I'm a big lady, so I weigh not quite, but close to 100 kilos. So if I'm 100 kilos, if you're going to dose my Lasix as if I was a child, you're going to give me 100 milligrams of Lasix. You know what's going to happen? You're not going to see me for about 4 hours, and when you do see me, I'll bet you money that I've lost 2 or 3 pounds, because all I've done is sit in the bathroom. Because we're very good at utilizing and absorbing medications, because our organs as adults function at 100%. Children don't necessarily do that. Another thing, go back to Lasix again. If I'm an adult and I am on Lasix, what else am I probably going to need to be on? And I bet you're thinking it's going to be potassium, right? Because when you're taking Lasix, the next thing you know, you're urinating like crazy, and you're urinating out your potassium. With small children, their kidneys are not that mature yet. So when they pee, I like to call it stupid pee. They're peeing out fluid, but they usually don't pee out their electrolytes, which is kind of nice, because good luck trying to get a small child to take those potassium supplements, right? So that's something to keep in mind. Sub-Q. How much subcutaneous does an infant have? Not so much. How about IM? We don't give IMs in the butt to children, right? To small babies, because they haven't started walking yet, so their glutes have not developed yet. So when you're talking about giving IMs or sub-Qs in small children, infants, it gets to be a little challenging. So you start thinking, well, how am I going to guarantee that this kid is going to get this med? If IMs don't work really well and sub-Qs don't work really well, and you've already kind of and I didn't really mention too much, but they may not get absorbed too well in the GI tract either. So either we're going to have to give more of the med than you normally would think of, and that's already been calculated in when you look at normal dose ranges for kids. They know what kids will absorb, so that's why we do the higher rates. But you need to keep that in mind, that's why they're doing that. So a lot of times, if you want to guarantee that your patient is going to get the med, guess what route we're talking? We're talking IV. Because that's really the only one that's going to guarantee. Because if you notice under absorption, my 4th bullet talks about topicals are going to be more readily absorbed in infants than they are going to be in older kids. There are some things that we can't use in infants that we can use in older children and adults because they're absorbed too well into the body and they can end up with toxicity from it. Who knew? I hate to read slides, so I'm just going to kind of tell you to kind of look through this. So things will change differently in children than in adults when it comes to the blood-brain barrier. Kind of mentioned that their metabolism is a little higher, and they will excrete a lot more stupid pee at the beginning. Things to keep in mind when you're given meds, and I'm sure this will be covered again in other lectures, but I just like it because I just want to make sure we get it. Never ever give the kid a choice to say no, because what kid is going to be, dumb enough to say, of course I want that nasty medicine? So you give them choices that they can do. Do you want it with water? Do you want it with juice? Those kind of things. Do you want your pills first, or do you want the whatever else you're doing to them? You want to get your bath first, or do you want your medicines first? Things that you can give them a little bit of a choice, but you need to make sure that you don't give them a yes, no. Don't lie, because if you lie, every nurse that follows you, that is going to pay for your lie. Because if, think about the time you had something done at the doctor's office and the doctor said it wasn't going to hurt and it hurt like crazy. Aren't you emotionally scarred about that? And every time a doctor tells you it's not going to hurt, you don't believe them, do you? It's the same thing with the kids. You want to talk to the kid, not around the kid. So you want to make sure that you talk to the kid and make sure the parents are listening. But if you talk at a level that the children can understand, then you know for sure the parents will understand. When it comes to kids, especially for those of you who've not been around a lot of kids, I like the expression, you fake it till you make it. You want, show no fear. When you walk in the room, you want to be confident and positive and just kind of go with the flow and work with it. Take your cues from the parents. A lot of times when it's time to give meds to a kid, the parents will say, let me do it. My only strong reminder is you only do it when you're in the room. Do not let them, a lot of parents will say, well, I'll give it to them later. No. You do it now, or I'll take the med back and you call me when you're ready to give it. Do not leave the meds with the family, because it's your license in the future. Right now it's my license, and I'm not going to let you do it. There's a psychiatric thing out there called Munchausen by proxy that you may learn about later. I have had a couple experiences with parents. What Munchausen by proxy is, if you saw the movie The Sixth Sense, the lady that was giving her little girl the rat poison, that's Munchausen by proxy. You make the kid sick, so you are like the caretaker. And it's a psychiatric illness that you can permanently lose your children if you're diagnosed with. I kind of put some other slides on the end here to kind of help you have some age-based considerations for giving meds. I am not going to go through them, but I just put them here to kind of help you. I thought they were good ideas as you go through your time in peds. So they're here for reference, but I'm not going to keep talking about it. So that concludes this lecture. I hope you learned a little bit about how things are a little different in peds versus adults.